Welcome back to the deep dive. Today we're doing something, well, a bit different. We're stepping away from our usual format and right into the pressure cooker of medical exams. For this deep dive, I'm playing the role of a postgraduate resident. I'm tired, probably overcaffeinated, and definitely stressing about the Gujarat University MD anesthesiology exams.
And I'll be your senior MD faculty member. Think of me as the external examiner who's going to be sitting right across from you in the Viva, deciding your fate.
Okay, so this is it, the real deal.
Exactly. We're going to run this just like a final prep session, no holding back.
Good, because my textbooks are open. I've got Guyton Miller, O's ICU manual, all spread out here, and my notes are a total mess. The topic we're tackling today is corticosteroids.
A classic. A perfect choice. And let me be very clear right from the start. If you're sitting for your MD or even the DNB, this isn't a topic you just skim.
Really?
Corticosteroids are what I'd call a make or break topic.
Make or break? Why so high stakes? I mean, we use them every single day. It feels almost routine.
And that's exactly what makes it so dangerous. It's ubiquity. You'll see it as a full 20-mark long answer question. You'll definitely find it as a short note, something specific like stress dose steroids.
Or adrenal crisis.
Or adrenal crisis, yes. And I can almost guarantee you in the Viva Voce, some examiner is going to drill you on adrenal suppression. Or the pharmacology, the difference between dexamethasone and hydrocortisone.
If you fumble that.
If you fumble that, it looks very, very bad. It suggests a gap in core knowledge. These drugs are the absolute bread and butter of the ICU and the operating theater. Look, if you don't know propofol, you're in trouble. If you don't know steroids, you're potentially dangerous.
Understood. Okay, so the mission today is to take all this scattered information, the physiology, the pharmacology, the critical care stuff, and build it into a structured answer that an examiner is going to love.
Precisely. We are building the perfect long answer from the ground up. We'll start with the adrenal cortex physiology, then classification, mechanism of action. That's where people usually get confused. And then we'll dive deep into the anesthetic side, and of course, the dreaded stress dose issue.
All right, let's start at the very beginning. Section 1.
Yeah.
The introduction. If I'm writing this in a theory paper, how do I frame it so the examiner sits up and takes notice?
You keep it crisp. Definitions first, always. Start with. Corticosteroids are steroid hormones. They're synthesized from cholesterol, specifically in the adrenal cortex.
Simple enough.
Then, immediately, you make your first critical distinction. You separate endogenous steroids.
The ones our body makes?
From synthetic steroids, the ones that come out of a vial.
Why is that distinction so important to make right at the top?
Because it shows the examiner you understand the fundamental philosophy of what we're doing. When we give steroids in the OR, we are mimicking and often we're aggressively amplifying a natural process.
We're hijacking a survival mechanism.
We're hijacking a survival mechanism. That's a perfect way to put it. You show that understanding and you've already scored points.
Okay, got it. Synthesized from cholesterol, mimicking natural hormones. Let's move on. Section 2. Physiology of the adrenal cortex. My notes have very high yield, written next to this in big capital letters.
It's the foundation. It really is. You can't grasp the pharmacology. You can't predict the side effects if you don't know where they come from. So you have to visualize the gland. It's sitting there on top of the kidney like a little cap.
And it has two parts, the cortex and the medulla.
Right. And for today, we're completely ignoring the medulla. No catecholamines for us. We are focused 100% on the outer part, the cortex.
Okay, and the cortex has layers. There's that famous mnemonic that every med student learns.
GFR, just like glomerular filtration rate, but it's not. Here it stands for the layers from the outside in, zona glomerulosa.
Zona fasciculata.
And zona reticularis, GFR.
And the hormones they produce. There's a mnemonic for that too.
It continues. Salt, sugar, sex, goes deeper, gets better.
Right. Let's break that down for an exam answer.
So the outermost layer, the zona glomerulosa. That's your salt. It produces the mineralocorticoids, the main one being aldosterone.
Then the middle layer, the fasciculata, that's the whitest one.
That's your sugar. It's producing the glucocorticoids, the star of our show today, cortisol.
And the innermost layer, the reticularis.
That's sex. It's producing the androgens, the sex steroids.
Okay, GFR, salt, sugar, sex. That's pretty easy to recall, even under pressure. But the regulation of these layers, that feels like a classic Viva trap. They don't all respond to the same signal, do they?
They do not. And you're right, it is a classic trap. Here is the piece of nuance that you absolutely have to nail. The zona glomerulosa, the salt layer, is effectively independent of the pituitary gland.
It doesn't care about ACTH.
It doesn't care very much about ACTH, no. It's primarily controlled by the renin-angiotensin system, specifically angiotensin II, and by the potassium level in the blood.
So if I have a patient with pituitary failure, say a pan-hypopit patient, they lose their cortisol, obviously, but their salt balance might still be okay.
That is a brilliant observation, and that's exactly the kind of connection an examiner wants to hear you make. In pituitary failure, ACTH is gone. So the fasciculata and the reticularis, they shut down. But the glomerulosa keeps ticking along because it's listening to the kidney, not the brain.
But the fasciculata, the cortisol layer, is totally dependent on ACTH.
100%. No ACTH from the pituitary, no cortisol from the adrenal.
Okay, let's talk numbers. Cortisol production. I've seen different values in different books. Guyton says one thing, O says another. What's a safe number to quote?
In a normal, unstressed state, the daily output is somewhere in the range of 15 to 30 milligrams a day. If you say 20 to 25 milligrams, you're perfectly safe.
Okay.
But honestly, the absolute number at baseline matters less than the capacity. This is the key concept for us in anesthesia. Under maximum physiological stress, we're talking major trauma, sepsis, a huge burn. That output can skyrocket.
How high?
It can go up to 350 milligrams a day. That's more than a 10-fold increase. That massive reserve capacity is what keeps a person alive during surgery. If your body can't mount that surge, you're in deep trouble. That's the whole basis of stress dosing.
And it's not a constant production throughout the day. There's a rhythm to it.
Correct. It's a diurnal variation, a circadian rhythm. The levels are highest in the early morning around 8 a.m. It's getting you ready to face the day.
And lowest at night.
Lowest around midnight. And this is clinically vital. If you're investigating a patient for an adrenal problem, the time you draw the blood completely changes how you interpret the result. A normal cortisol level at midnight might actually be pathologically high.
Suggesting something like Cushing's.
Exactly. Whereas a normal level at 8 a.m. is what you'd expect.
We can't leave this section without talking about the HPA axis, the control loop.
Absolutely not. The hypothalamic pituitary adrenal axis. It is a strict top-down hierarchy. The hypothalamus at the top releases CRH, corticotropin-releasing hormone.
That travels down to the anterior pituitary, which then releases ACTH.
Adrenocorticotropic hormone, yes. ACTH then travels through the bloodstream to the adrenal cortex and gives the order. Release cortisol.
And then the cortisol feeds back and shuts down the system.
The negative feedback loop. Cortisol goes back and inhibits both the hypothalamus and the pituitary. It essentially says, okay, we have enough now, you can stop shouting.
But stress breaks that loop.
Stress overrides it completely. This is the open loop concept during major stress. Any kind of severe physical or emotional stress trauma, surgery, pain, fear, it just blows right through that negative feedback. The brain says, I don't care how much cortisol is in the blood, I need more, N now W. And that's the stress response we manage in the theater.
Okay, that's a really solid foundation on the physiology. Let's move to section 3. Classification. This is pure exam core material. If I'm writing this out, what's the logical way to classify them?
You use two metrics at the same time. First, by their primary activity, are they more glucocorticoid or more mineralocorticoid? And second, by their duration of action. And for this, you have to know the potency table.
Do I need to memorize the exact decimal points, or is the relative value enough?
The relative values are what matter, and you must know them relative to your baseline, your reference standard, which is hydrocortisone.
So hydrocortisone is basically just cortisol in a vial.
Chemically, yes. So we give it a reference value of 1 for its glucocorticoid or anti-inflammatory activity, and a value of 1 for its mineralocorticoid or salt-retaining activity. It's the benchmark.
And it's short-acting.
Short-acting. Biological half-life of about 8 to 12 hours.
Okay, then we move to the intermediate group. That's prednisolone and methylprednisolone, right?
Right. These are the workhorses for chronic inflammatory diseases. Prednisolone is about 4 times more potent than hydrocortisone as an anti-inflammatory, but, and this is important, its mineralocorticoid activity is a bit less, about 0.8.
And methylprednisolone is a step up from that.
A little bit, yeah. About 5 times the anti-inflammatory potency, and even less mineralocorticoid effect, maybe 0.5. You can see the trend. Drug designers are trying to separate the desired anti-inflammatory effect from the unwanted salt retention.
And these are intermediate acting.
Lasting 12 to 36 hours.
Okay. And then we have the big gun, the one we use at induction, the one for neurosurgery, dexamethasone.
And here comes the Viva trap. Dexamethasone is long-acting. Its effects can last for more than 36 hours. Its glucocorticoid potency is huge, 25 to 30 times that of hydrocortisone.
Yeah.
But, and this is the million-dollar question, what is its mineralocorticoid activity?
It should be 0.
It is 0. And that is why it's perfect for something like cerebral edema. You want a massive anti-inflammatory effect inside the closed box of the skull, but you absolutely do not want to cause any fluid retention.
So if you tell an examiner that dexamethasone causes salt retention,
You will fail that station. I can almost guarantee it. It's just a fundamental misunderstanding of why we choose specific drugs.
got it. So to summarize, hydrocortisone, short, balanced 1-to-1. Prednisolone, intermediate, more anti-inflammatory, 4 to 0.8. Dexamethasone, long-acting, pure anti-inflammatory, 30 to 0.
That's the summary you deliver. Perfectly.
All right, let's go even deeper now. Section 4, mechanism of action. This is another high-yield topic, I think, because examiners love to ask why steroids don't work instantly.
They love it.
You give a bolus of Dex for airway edema, but the stridor doesn't just vanish in 30 seconds like it would with nebulized adrenaline. Why the delay?
Because it has to talk to your DNA. This is the genomic effect, the slow pathway. The steroid molecule itself is lipid soluble, so it slides right through the cell membrane. Doesn't need a pump or a channel.
And once it's inside the cell,
Inside the cytoplasm, it finds its specific receptor, the glucocorticoid receptor, or GR. Now, this receptor isn't just floating around waiting. It's usually bound and held inactive by a chaperone protein. You should name it. Heat shock protein 90.
HSP90.
Think of HSP90 as a bodyguard, just keeping the receptor quiet.
So the steroid comes in, binds to the receptor, and the bodyguard gets kicked out.
Exactly. The binding causes a shape change. The HSP90 falls off. The now active receptor steroid complex then finds a partner, it dimerizes, and this pair marches into the cell's nucleus.
And once it's in the nucleus, it binds to the DNA.
To specific sequences on the DNA called glucocorticoid response elements, or GREs, and by binding there, it changes gene transcription. It's like a manager walking onto the factory floor.
It can ramp up production of some things.
Like anti-inflammatory proteins, or it can shut down production of others, like pro-inflammatory cytokines. It directly modifies mRNA synthesis.
And making new proteins? That takes time.
It's not instant. It's like ordering a book from a printing press. You can't just wish it into existence. It takes a minimum of 30 to 60 minutes and often hours for those new proteins to be made and start having an effect. That's your time lag.
Wait, sometimes we do see faster effects, don't we?
We do, and that's what's called the non-genomic effect. It's less well understood, but we think there may be some receptors on the cell membrane or maybe some direct physicochemical interactions that can happen in seconds or minutes. But for your exam answer, you lead with the genomic pathway. That's the main event.
Okay. What about the specific anti-inflammatory mechanism? That's a classic pharmacology question. Contrast the anti-inflammatory mechanism of steroids with NSAIDs.
It's an elegant mechanism. Steroids work by inducing the synthesis of a protein called annexin A1. It used to be called lipocortin.
And annexin inhibits phospholipase A2.
Correct. And you have to know what phospholipase A2 does. It's the enzyme that snips arachidonic acid out of the cell membrane phospholipids.
Right. And arachidonic acid is the precursor for the entire inflammatory cascade. Prostaglandins on one side, leukotrienes on the other.
Precisely. Prostaglandins via the COX pathway, leukotrienes via the lipoxygenase pathway. So by blocking phospholipase A2 at the very top, steroids cut off the supply of the raw material.
Whereas NSAIDs only block the CoAPX pathway downstream.
Exactly. NSAIDs stop prostaglandins, but they don't touch leukotrienes. Steroids stop both. They turn off the tap right at the source. It's why they're so incredibly potent as anti-inflammatories, but also why they're so broadly immunosuppressive.
That's a great way to put it. NSAIDs are downstream, steroids are upstream. Okay, let's touch on pharmacokinetics briefly before we hit the big clinical sections.
Sure. So for pharmacokinetics, absorption is excellent by almost any route you can think of. Oral, 5E, IM, topical, inhaled. It gets in.
And metabolism.
Primarily hepatic. The liver reduces it and then conjugates it with things like glucuronic acid to make it water-soluble so the kidneys can excrete it. But there's a key concept here you must mention. It's the half-life discrepancy.
The half-life discrepancy. What's that?
It's the difference between how long the drug is in the blood versus how long its effect lasts. The plasma half-life can be quite short. For hydrocortisone, it's only about 90 minutes.
But the biological half-life is much longer.
Much longer, up to 12 hours.
And why is that?
It's because of that genomic effect we just talked about. The drug molecule might be gone from the plasma, but the new proteins it ordered the cell to make, that's still inside the cell doing their job. The messenger is gone, but the message has been delivered and is being acted upon.
That makes perfect sense. Okay, section 6. Pharmacodynamic effects. This is an exam favorite. What does the drug actually do to the body?
The best way to answer this is to go system by system. Start with metabolic. It's in the name. Glucocorticoid. They raise blood glucose.
Oh.
They promote gluconeogenesis in the liver, making new sugar from scratch, and they cause insulin resistance in the peripheral tissues. The net effect is hyperglycemia.
Which is a huge problem in the ICU, especially with septic patients.
Wow.
What about protein and fat?
On protein, they're catabolic. They break down muscle to provide amino acids for that gluconeogenesis. This leads to muscle wasting and weakness. And with fat, they cause both lipolysis breakdown and redistribution. That's what leads to the classic Cushingoid features, the buffalo hump and the moon face.
Okay, cardiovascular effects. This seems critical for anesthesia.
Absolutely critical. The key phrase to use is permissive action.
Can you explain that simply? I always find that concept a bit hard to articulate clearly in a Viva.
Think of it this way. Your blood vessels are like a stereo speaker. Catecholamines, like noradrenaline, are the music. Cortisol is the volume knob.
Okay.
If you don't have enough cortisol, the volume knob is turned all the way down to 0. You can blast all the noradrenaline you want. You won't hear any music. You won't get any vasoconstriction. You need the steroid to be present to turn the volume knob up, to allow the vascular smooth muscle to hear and respond to the vasopressor.
Ah, okay. That perfectly explains why we use it in refractory septic shock. The patient isn't just hypotensive, they're deaf to our pressors.
Precisely. Without cortisol, the alpha receptors on the vessels get downregulated or uncoupled. You give back the cortisol, you restore that sensitivity.
What about electrolytes?
That's the mineralocorticoid effect.
Uh-huh.
Sodium retention and potassium excretion. So you can see hypernatremia and hypokalemia.
And finally, the big one, the immunosuppressive effects.
They do everything. They inhibit the recruitment of leukocytes to sites of inflammation. They suppress T-cell proliferation. They block the production of major cytokines like interleukin-1, interleukin-6, and TNF-alpha. It's a total shutdown of the immune response.
Great for an organ transplant, not so great for a post-op patient fighting an infection.
You've got it. Okay, let's apply all this. Section 7. Clinical uses. High yield. Where do we actually use these drugs in our world?
Well, the most obvious one is replacement therapy for adrenal insufficiency, Addison's disease.
Right. But in the ICU, the big one everyone talks about is septic shock, specifically refractory shock.
So the patient who is still hypotensive even after you fill the tank with fluids and you're cranking up the vasopressors.
Yes. The surviving sepsis guidelines suggest considering IV hydrocortisone in those patients. The typical dose is around 200 milligrams per day.
Usually given as 50 milligrams every 6 hours or 100 milligrams every 8.
Correct. And we're looking for that permissive effect on the blood vessels. Now, a key point. We do not use dexamethasone here. Why not?
Because dexamethasone has zero mineralocorticoid effect. In a shock state, you actually want a little bit of that salt and water retention to help keep the intravascular volume up.
Perfect. Hydrocortisone gives you both glucocorticoid and mineralocorticoid action. What about in the brain? Cerebral edema.
That's dexamethasone's territory.
King of the brain. High potency, zero salt retention. The last thing you want in a patient with a swollen brain is to make them fluid overloaded. It's particularly good for edema associated with tumors. It seems to tighten the blood-brain barrier.
But not for trauma.
We'll get to that contraindication. It's an absolute one, but yes, not for trauma. What about airway edema?
A classic indication, post-extubation stridor.
Or croup in children. Again, dexamethasone is often preferred because of its long duration of action. You give one dose and it provides anti-inflammatory cover for over 36 hours while that laryngeal swelling subsides.
And finally, as an antiemetic.
A staple for PONV prophylaxis. A small dose, maybe 4 to 8 milligrams of dexamethasone the fourth, given right at induction. The mechanism isn't perfectly understood, but it's probably a combination of central action on the chemoreceptor trigger zone and inhibiting prostaglandin synthesis.
So moving into our specific domain now, Section 8, steroids in anesthesia. We've touched on a few things, but what about the overall perioperative stress response?
Well, any major surgery is a controlled trauma. It unleashes a storm of cytokines. In very large surgeries, like cardiac bypass, some studies have looked at using steroids to blunt that massive inflammatory surge, trying to reduce post-op complications.
And in neurosurgery, it's not just about edema.
No, it's essential for managing intracranial pressure, especially around tumors.
Okay, now for what is arguably the most important practical section for any anesthesia resident. Section 9, perioperative steroid supplementation. the stress dose.
This is the consult you will get at 2 a.m. from a surgical colleague. My patient's on 10 milligrams of prednisone for her rheumatoid arthritis. What do I do for her appendectomy tomorrow?
So the first question we have to answer is, who is actually at risk? Who has a suppressed HPA axis?
The safe rule of thumb for your exams and for clinical practice is this. Any patient taking more than 5 milligrams of prednisone per day, or its equivalent, for more than 1 month in the past 6 to 12 months.
Why that specific cutoff?
Because that dose, for that duration, is enough chronic negative feedback to tell the patient's own pituitary and hypothalamus to just go to sleep. The adrenal glands aren't getting any stimulation from ACTH, so they atrophy. They shrink.
So if you suddenly hit that patient with the massive stress of surgery,
Their own adrenals can't wake up in time. They can't produce that 350 milligram surge we talked about. They can't maintain their own blood pressure.
and they collapse into an adrenal crisis on the table.
Exactly. Refractory hypotension and shock.
So what's the strategy? I know there used to be a sort of mega dose for everyone philosophy.
Historically, yes. We used to give huge doses just to be safe. The modern approach, and the term you should use in your exam to show you're up to date, is physiological mimicry. We try to match the dose to the degree of surgical stress. We don't want to massively overdose them if we don't have to.
Okay, so can you walk me through the concepts for different levels of surgery?
Of course. Let's start with minor surgery. We're talking a cataract block, a colonoscopy, maybe a small skin lesion excision.
Okay.
For these, the patient just takes their usual morning dose of their steroid. That's it. No extra stress means no extra steroid is needed.
Makes sense. What about moderate stress? Say a laparoscopic cholecystectomy or total hip replacement.
Here you definitely need a stress dose. Typically we use IV hydrocortisone. A common regimen would be maybe 50 milligrams on induction and then perhaps 25 milligrams every 8 hours for the first 24 hours. You're just bridging them over that initial most stressful period.
And for major stress, cardiac surgery, Whipple's, major trauma.
Then you go higher. Something like 100 milligrams of hydrocortisone on induction, followed by 100 milligrams per day, often in divided doses, until they're stable in the ICU. Then you gradually taper them back to their usual oral dose over a few days.
So the core concept is their factory is offline, so we have to manually provide the hormone they need to survive the stress.
That is it, precisely. And omitting this is a potentially fatal error. In Viva, if you fail to ask about a patient's steroid history in the pre-op assessment, that's a critical safety failure. You could kill the patient.
Speaking of fatal, let's talk more about the adrenal crisis itself. Section 10. What does it look like when it happens?
It looks like shock that just doesn't respond to anything. It's refractory hypotension. You give a fluid bolus, the BP doesn't move. You give a vasopressor, it comes up for a minute and then just drifts back down. But the real clues are in the lab results.
Okay.
If it's primary adrenal insufficiency, like Addison's, they've lost aldosterone as well as cortisol. So you'll see hyponatremia, low sodium, and hyperkalemia, high potassium.
It'll be hypoglycemic.
Yes, because they've lost that glucocorticoid effect on blood sugar. They've simply run out of fuel.
And the emergency management.
KBC's first, always. Then it's fluids, fluids, and more fluids. Normal saline is the fluid of choice because they're hyponatremic. And then the critical step, hydrocortisone. 100 milligrams 5-stat, then start an infusion or continue with boluses every 8 hours.
And support everything else.
Support the glucose with dextrose, support the blood pressure with vasopressors if you still need them. But the key is this, do not wait for a cortisol level to come back from the lab. If you clinically suspect adrenal crisis, you treat it immediately.
Okay, so we're treating them with steroids, but we know these drugs aren't benign. Section 11. Adverse effects. What's the list I need to have ready?
You need to be able to rattle these off by system. So, metabolic, hyperglycemia, you have to be aggressive with insulin, especially in diabetic patients. Musculoskeletal, myopathy, we see this a lot in the ICU critical illness myopathy, often a combination of high-dose steroids and neuromuscular blockers.
For long term.
Osteoporosis is a huge one. And a vascular necrosis of the femoral head, a classic board question. Patients who were on high-dose steroids years ago now needing hip replacements.
Gastrointestinal.
Peptic ulceration. Interestingly, the risk from steroids alone is actually pretty low. But if you combine steroids with NSAIDs,
Like we do all the time for post-doc.
exactly, that combination makes the risk of a GI bleed skyrocket. You have to be very cautious.
In the immune system.
Increased risk of infection is the big one. And what's worse, steroids can mask the signs of infection. The parent might not mount a fever or a high white cell count, even while they're becoming septic. Also, delayed wound healing is a major surgical concern, especially for things like bowel anastomosis.
Right, they inhibit collagen.
Yeah.
And we can't forget the CNS effect.
Absolutely not. Steroid rage, psychosis, mania, but even acutely, they can cause severe insomnia and delirium in the ICU.
Okay, so with all those risks, when are they contraindicated? Section 12.
For the most part, they are relative contraindications. So an active, uncontrolled systemic infection is a big one, unless, of course, the reason you're giving it is for that infection, like in septic shock.
Or bacterial meningitis.
Or bacterial meningitis, yes. Diabetes is another. Not a contraindication, but a major precaution. You have to be ready to manage the hyperglycemia. Same with active peptic ulcer disease.
Is there any ICU-specific absolute contraindication, something we just never, ever do?
Yes. Traumatic brain injury, TBI. This comes from the CRS trial, a massive study. For years, we thought steroids might help with brain swelling after trauma because they work so well for brain tumors. The trial showed the exact opposite. They actually increased mortality.
So steroids for brain tumor edema, yes. Steroids for brain trauma edema, absolutely not.
That is a critical evidence-based distinction you must make.
Okay, this is all fantastic. Now let's get into the exam room itself. Section 13, Viva traps. What are the common mistakes students make?
Okay, trap number 1 is potency versus efficacy. Students see that dexamethasone is 30 times more potent than hydrocortisone and think it must be better for everything.
It's not.
It's not. For an Addisonian crisis, it's actually the wrong drug. You need the mineralocorticoid effect of hydrocortisone to fix the salt and potassium problems. If you gave dexamethasone alone, you'd have to add a separate mineralocorticoid like fludrocortisone.
Okay, what's trap number 2?
Expecting an instant fix. You give hydrocortisone for refractory hypotension. Don't stare at the arterial line trace expecting the blood pressure to jump up in 30 seconds. Remember the genomic mechanism? It takes time. Catecholamines work now. Steroids work over the next few hours to maintain that stability.
In trap 3, I think I know this one.
It's forgetting the history. I cannot say this enough. If your patient becomes profoundly hypotensive on induction and you never asked if they take chronic steroids, you have missed the most likely diagnosis. The examiner will fail you on the grounds of patient safety.
Okay, so I've avoided the traps. I'm at the whiteboard.
Yeah.
Section 14, diagrams. What do I draw to impress the examiner?
You draw 4 simple, clean diagrams. 1, a cross-section of the adrenal gland. Show the cortex with the 3 layers, G, F, R, and the medulla. Label the key hormones for each layer.
Got it.
2, the HPA axis flowchart. A simple box for hypothalamus, 1 for pituitary, 1 for adrenal. Arrows showing CRH and ACTH going down, and a dotted line showing cortisol's negative feedback going up.
Okay, 3.
3, the mechanism of action. Draw a cell. Show the steroid diffusing in, binding the cytoplasmic receptor, the complex entering the nucleus and binding to DNA to alter mRNA. Label it genomic pathway.
And the 4th?
A conceptual sketch of the steroid nucleus, just the 4-ring structure, the cyclopentanoperhydrofuranthine ring. You don't need to be a chemist, but drawing the basic shape shows you know where it all comes from.
Excellent. Okay, we've covered a massive amount of ground. Let's bring it all home. Section 15, summary and the perfect exam conclusion. Give me the closing argument.
All right. Here is the model conclusion paragraph you should have ready to write or say. In conclusion, corticosteroids are life-saving, cholesterol-derived hormones with profound and widespread physiological effects. For the anesthetist, their management hinges on 2 core principles: recognizing HPA axis suppression to prevent perioperative adrenal crisis with appropriate stress dose supplementation, and understanding the distinct pharmacology to guide clinical selection. The choice between hydrocortisone for crisis management with its dual activity and dexamethasone for cerebral edema, or PONV, with its pure glucocorticoid effect exemplifies this principle. While immensely powerful, their use demands constant vigilance for the significant adverse effects, particularly hyperglycemia, immunosuppression, and delayed wound healing.
Wow, that's a 20-mark answer right there. It's concise, it's technical, and it's clinically focused.
It hits the basic science, the pharmacology, and the practical application. You deliver that with confidence, and the examiner will nod and move on, satisfied.
Thank you. I genuinely feel like the fog has cleared. I'm much more confident about differentiating the types and, crucially, when and why to use each one.
Just keep it simple. Remember GFR, remember the potency table, and for the love of God, always ask about the steroid history. You'll be fine. Good luck with the exams.
And to everyone listening, we hope this deep dive has helped structure your own revision. Go on, close your eyes and visualize that HPA axis right now. We'll see you next time.